than 1 million people in the United States are living with HIV. We are your family, friends, and others that you love. HIV does not define who we are. When you support us, you make it easier for us to live healthy lives. We all have the power to stop HIV stigma.
At VA, we are building a high-performing, integrated community care network so that veterans get the right care at the right time from the right provider. To design this network, we listened to feedback from veterans and their families, veteran service organizations, community providers, and industry leaders and VA staff. We heard several major themes from these discussions, including the need to follow contemporary industry standards and to be able to customize the network to local markets and veteran population needs. Based on this feedback, the new Community Care Network has several important features that improve the care coordination process between VA, community providers, and third-party administrators. This includes distribution across 4 regions along state lines with separate arrangements for Alaska, American Samoa, Guam, and the Northern Mariana Islands. Development of a complementary alternative medicine network. A focus on transparency, accountability, and quality monitoring. Stronger communication between veterans, community providers, and VA, and an emphasis on timely, accurate payments. A key aspect of the new network is that it provides direct communication between veterans, VA, and community providers. In contrast to the previous network, VA directly coordinates eligibility, referrals, authorizations, and medical documentation with community providers, while third-party administrators, or TPAs, only coordinate back-end administrative processes, including claim submissions, claim payments, and remittance advice. As a result, the new network design improves customer service for veterans by reducing handoffs and cutting red tape, ensures veteran option for community care, providers, and scheduling, and helps modernize processes by moving towards electronic communication between VA and community providers. The new Community Care Network is part of VA's larger efforts to transform VA so that veterans have access to timely, high-quality care.
If you were born from 1945 to 1965, you'll want to listen to this. People born during these years are 5 times more likely to have hepatitis C. It often has no symptoms, yet is a leading cause of liver cancer. Here's the good news. Treatments are available that can cure this disease. Talk with your doctor about getting a blood test for hepatitis C, because you still have a lot to look forward to.
Welcome to Beyond the Data. I'm Dr. Phoebe Thorpe, and here with me today is Dr. Stephen Patrick from Vanderbilt University. Thank you for joining us.
Thanks for having me.
Today's session is about neonatal abstinence syndrome. Tell me, what is neonatal abstinence syndrome?
Well, neonatal abstinence syndrome is a drug withdrawal syndrome that newborns experience shortly after birth. It happens after they've been chronically exposed to opioids in utero before delivery. And what it typically looks like is, I typically describe it as a colicky baby times 5. It's a baby that's very fussy. They may have tremors, jitteriness. Sometimes they can have difficulty feeding enough where they require a feeding tube. And less commonly, they can also have seizures. And what we know is that as the prescription opioid epidemic has grown over the last several years, we've seen an increase in the number of babies that have drug withdrawal. And some of our research suggests that there's been about a 5-fold increase in the number of infants having drug withdrawal over the last decade. And by 2012, about 1 infant was born every 25 minutes having drug withdrawal in the United States.
Oh, that's a lot. So what is being done to treat these babies with the NAS?
Well, you know, one of the things that's happened over the last several years is that as the increases of infants with neonatal abstinence syndrome has occurred, the evidence base for what to do to treat them most effectively hasn't really been there. And we've seen a lot of variability from hospital to hospital on what's being done. So what we know as is becoming more and more apparent is that if we can begin to de-escalate some of the care, if we can keep mom and baby together, not separate mom and baby, that seems intuitive that we'd want to do that. But traditionally what's happened is that the infant gets taken away from mom and put into a neonatal intensive care unit where I work as a neonatologist. And that's a very loud environment. It can be chaotic, not a great place to go through if you're having drug withdrawal. So one of the best things that we're beginning to see is that if we keep mom and baby together and we control the environment, we promote breastfeeding when it's appropriate, and we begin to standardize the care that's given. We do things the same way every time. That appears to be more effective. And keeping mom and baby together, those sort of things that don't include giving a medicine, seems to control the symptoms that the babies have to require less medicine. But sometimes withdrawal is severe enough to where we do have to treat it with a medication. And we know that opioid withdrawal for babies is best treated with an opioid, like morphine or methadone.
So part of the problem is that the moms, it's a chronic exposure to the baby while it's inside the mom before it's born. What's being done to help and treat the moms during pregnancy?
So standard of care for treating a woman with opioid use disorder in pregnancy is medication-assisted treatment, drugs like methadone or buprenorphine. We know that improves outcomes for the mother. She's less likely to relapse, less likely to get things like hepatitis C. And for the baby, they're more likely to go to term and have higher birth weights. But that those better outcomes are balanced by the increased risk of neonatal abstinence syndrome. One of the things that we're finding over time is that it's difficult for many women to find access to treatment. And as we've had so many more people that are now requiring treatment for opioid use disorder, finding treatment, particularly specialized treatment for pregnant women, is challenging. And one of the things that's happened more recently is some additional attention to that, including in the recently passed Comprehensive Addiction and Recovery Act that was passed by Congress just a few weeks ago, with a special focus on family-centered care for women with opioid use disorder.
And what is that act going to, what's the intent that it's going to help provide?
Well, it has pilot programs and grants to help facilitate, to help enable states to begin some programs for family-centered care. You know, in Nashville, where I live, there are very few family-oriented places. You can imagine a young mom with a long history of opioid use disorder who delivers an infant and may have another couple of kids, trying to do everything right and trying to find resources for her kids and having no place to sort of go in residential treatment with her infants and her other kids maybe. And so there are a few places like that. Mm-hmm. Nashville has one. Mm-hmm. That beginning to sort of have family-centered comprehensive care is better for mom and better for baby. And I think that's one of the things that we really need to come around to understanding is that addiction is a chronic relapsing disease. It's a disease, not a moral failing. And we need to begin to view that like we do other chronic relapsing diseases like diabetes and think about how do we expand treatment for it, mm-hmm. Particularly for pregnant women. And one of the things that we begin to focus on too is primary prevention. How do we begin to control unnecessary prescribing, eliminating opioid use disorder before it becomes a problem, far before pregnancy, and making sure that every pregnancy is planned too, that we expand access to things like long-acting reversible contraception.
Yes, and you've hit on many, many important topics. As you were talking, I was thinking about the Surgeon General just has labeled it as an opiate crisis. And when we have a crisis, normally we have a kind of large-scale coordinated response. And so some of what I hear you saying is about healthcare providers and what they can do. And can you expand a little bit more on that? Yeah,
I think we're beginning to realize that that we're using a lot of opioids. The Surgeon General has done work recently on this. The CDC has provided data to this for a long time now. In 2012, there were 259 million prescriptions for opioid pain relievers written in the United States. And in my state, in Tennessee, we have the second highest rate of opioid prescribing, about 1.5 prescriptions per person in the state. So it shouldn't be much of a surprise that we're beginning to see complications like overdose deaths and treatment facility admissions. And one of the things that we're seeing, of course, in my NICU is another complication from that, and that's neonatal abstinence syndrome. And so I think we're beginning to see things like the Surgeon General talking about prescription opioids more, talking to providers to think about what you're doing when you prescribe. You know, as the CDC, as the guidelines say, start low and go slow. Mm-hmm. And the Surgeon General really sort of calling to providers to really think about what you're doing before you prescribe. And certainly there are needs for pain medicine, but pain medicine should be used when it's appropriate and necessary. And there are also disparities that are in our system. You know, we have this system where we have perhaps overprescribing in some settings and still underutilization and undertreatment of pain in minority communities in many cases. And so it's a complicated situation, and in part, that's why this really requires a thoughtful public health approach that's grounded in primary prevention and goes towards expanding treatment, and again, thinking about addiction as a disease and not as a moral failing.
Yeah, that's a good point. And the other thing that what other policies, or what else would you want policymakers to do to help with this crisis?
Well, I think, we recently saw the Comprehensive Addiction Recovery Act that was passed by both the Senate and the House and signed by the President, and I think that's a nice step forward. What I hope in the coming months happens is that we see that fully funded. I think that's an important step for our policymakers to make. And what we've seen is, some of our work has been looking at, how have some of these policies worked? Things like prescription drug monitoring programs. And what these programs do, they're databases where if I, as a prescriber, write a prescription for an opioid, someone goes and fills that prescription at a pharmacy, and then there's a database that collects those data. And we can monitor high-risk prescriber behaviors if I'm writing a whole bunch of an opioid, or high-risk patient behaviors if they're going from doctor to doctor to doctor to get a prescription. Some of our research suggests that PDMPs, or prescription drug monitoring programs, have been effective in reducing overdose deaths, and that's pretty important. So beginning to bolster these programs and support what we know is working in many communities, like prescription drug monitoring programs, beginning to educate the public and providers about prescribing, beginning to expand access to treatment, beginning to expand things like over-the-counter access to naloxone to save people's lives if they're having an overdose. Those are really important steps as we begin to respond.
Thank you so much for joining us. These are all very, very important points, and the session was just great. I really appreciate your work, and I think that you have done a fabulous job, phenomenal even, about putting a face on this part of the opioid crisis that was hidden. And I appreciate your work with treating the most vulnerable parts of our society. Thank you.
Thank you. It's been an honor to be here.
And thank you for joining us. Join us next month for Beyond the Data.
Chances are you've heard something about probiotics. Hi, I'm Dr. Griffin Rogers with the National Institutes of Health. What are probiotics? Do they have health benefits? My colleague, Dr. Josie Briggs, Director of the National Center for Complementary and Integrative Health at NIH, explains.
Keeping the balance between good and bad bacteria in our body helps us stay healthy. Things like medications and diseases can upset that balance. Probiotics are live bacteria that are similar to the good bacteria found naturally in our gut. They can help keep your gut healthy and come in products such as dietary supplements and in dairy foods such as yogurts. Now, the FDA has not approved any health claims for probiotics, but there is evidence that probiotics might help conditions such as the diarrhea that can be caused by antibiotics. Talk to your doctor before using any kind of supplement, including probiotics.
Follow us on Twitter at NIDDKGov.
When a public health emergency happens, what you hear about how CDC responds is just part of the story. Several years ago, at 1 a.m. on a Sunday, this conference room and the CDC Emergency Operations Center behind me were full. It was April 2009, and we had just reported a novel or new flu strain, H1N1. By June, the World Health Organization signaled that a global pandemic of novel influenza A was underway. So, what happens when we identify an outbreak?
CDC is on the job 24/7, so we're always watching and analyzing the data. And when that call comes in, or we notice something is not right, we gather the best of the best, and we move quickly. In a matter of hours, we talk with federal, state, and local partners. We make sure we're physically ready to be deployed. We get the equipment we need for field deployment. We start testing in the lab immediately. We train our people to make sure they are safe. We communicate what we know. We go door to door to find cases and identify contacts. We report from field offices, Or what passes for a field office? We connect the dots. We use what we find out to let people know how to protect themselves and their families.
And we keep going. Our Emergency Operations Center has been activated almost 90% over the past several years, responding to more than 100 outbreaks involving all 50 states and more than 50 countries, sending hundreds of doctors, epidemiologists, statisticians, nurses, communicators, biologists, virologists, mosquito experts, and administrative staff, to name just a few, all focused on finding, stopping, and preventing future outbreaks, keeping Americans healthy and safe. There's a lot going on behind the headline, CDC Response.
Kicking a soccer ball, jumping rope, and shooting baskets. What do these activities have in common? Hi, I'm Dr. Griffin Rogers, Director of the National Institute of Diabetes, Digestive, and Kidney Diseases at NIH. All of these activities are fun ways for children to get physically fit and to improve their health. Our kids don't need to run marathons or take expensive classes, but they do need to be more active. Try these tips. Limit their TV and video game time, encourage them to get moving with fun activities, and lead by example. If your kids see you being physically active and having fun, they're more likely to join in and stick with it. Being active is a big deal. It can help your children avoid future health problems like diabetes and high blood pressure. To learn more tips to help your children stay active, follow us on Twitter at NIDDKGov. This is Dr. Griffin Rogers with the NIH.
Hi, I'm Angela James at the Centers for Medicare and Medicaid Services, and I've got some important information to share with you about women's health. Women have unique health concerns, including certain types of cancers and high rates of chronic disease, and women often avoid or delay preventive care, sometimes because of out-of-pocket costs. Screening tests are important because they can help find diseases early when the treatment can work the best. The good news is that women now have access to these important services at little or no cost. Women with Medicare can take advantage of many of these services right now. Some of these services include an annual wellness visit, bone mass measurement, cervical cancer screenings, mammograms, and cardiovascular screenings. Medicare also covers other preventive services, so talk to your doctor about risk factors and talk to your doctor to schedule your next screening. If you get your health care coverage through a Medicare Advantage plan like an HMO or PPO, call your plan for more information. To learn more, visit Medicare.gov.
I've been with CDC for almost 6 years. I work in the Division of Global Migration and Quarantine on the Global Border Health Team. I work with authorities in international airports and other points of entry in French-speaking West African countries to help them plan for infectious disease outbreaks. We help them develop public health emergency response plans and procedures, train staff, and conduct simulations so that they can better protect their country and the world, including the U.S., from the spread of disease. Our motto is that disease is only one flight away. Public health is everyone's responsibility. At airports and other points of entry, involving both health and non-health workers is critical to identifying and referring sick people to care, to help them and to protect the public. I studied French in college, and at first I wanted to be a linguist or an interpreter. Then, during my time in the Peace Corps, I decided that global public health was the direction I wanted to take to marry my interests in language, culture, and public service. So I pursued a Master of Public Health concentrating on global health. It is the perfect fit for me. If I weren't working at CDC, I'd like to work with a global health organization in crisis-stricken areas. Or else I'd be a barista, because I love coffee. I love what I do because I really believe it's making a difference in improving global health security, at home and abroad. I'm honored to be a part of it. I'm Amanda McGurn, and I am CDC.
I've been at CDC for 14 years. I work for the Division of Vector-Borne Diseases in Fort Collins, Colorado. I'm a research entomologist. I study mosquitoes and the best way to control them, including the impact of insecticide resistance. My path to public health arose because I love insects, I love helping people, and becoming a medical entomologist was a way that I could put the two together to do something I love. If I didn't work for CDC, I have two dream jobs. The first would be to work in a local mosquito control program, and the other would be to be a librarian. So I remember a situation where I went to Miami to work on a Zika virus outbreak, and I had to attend a city council meeting to discuss mosquito control. That's a topic that can be very controversial, and so there was a lot of shouting, there was a lot of anger, the media was there, so people were on edge, and it really made me feel intimidated. But the next day, when I was working in the community, there were a lot of people who came up to me and thanked me for the work that I was there doing. And so it really made me feel much better, like I was having a positive impact on the community. I get to help communities control mosquitoes, which protects everyone from mosquito-borne diseases, and that's one of CDC's goals. I'm Janet McAllister, and I am CDC.
Intimate partner violence is defined as physical violence, sexual violence, stalking, and psychological aggression by a current or former intimate partner, and is preventable.
Intimate partner violence threatens the well-being of millions of people and their families every single day. Intimate partners may include current or former spouses, boyfriends, girlfriends, dating partners, or sexual partners.
Intimate partner violence can occur between heterosexual or same-sex couples. Some victims may suffer just one experience, while others endure violence that lasts for years.
1 in 4 women and 1 in 9 men have experienced intimate partner violence in their lifetime. And 1 in 10 high school students have experienced physical teen dating violence, which is a form of intimate partner violence.
Intimate partner violence consequences are widespread.
It impacts physical and mental health. It results in billions of dollars in medical, mental health, and lost work productivity costs.
But the good news is that intimate partner violence is preventable. We have strategies that can help you prevent this problem in your community. We can prevent intimate partner violence by teaching safe and healthy relationship skills, engaging influential adults, working to prevent violence starting in early childhood, creating protective environments, strengthening economic support for families, and supporting survivors to increase safety and lessen harms.
The U.S. Cancer Statistics, USCS, brings together cancer data from CDC's National Program of Cancer Registries and the National Cancer Institute's Surveillance, Epidemiology, and End Results Program. It covers all 50 states, Washington, D.C., and Puerto Rico. USCS can be used to look at cancer trends over time, discover what groups are affected most by cancer, and find out if and when cancer screening and prevention are working. You can access this information through the Data Visualizations tool. Explore state and county level cancer data over time, create full color charts,
maps, and graphs, learn how to use the data, and much more. The Public Use Database, which includes over 24 million cancer cases, lets researchers analyze anonymous information about tumors and cancer patients. You can find it all at cdc.gov/cancer. U.S. Cancer Statistics, the official federal cancer statistics.
You may have heard about child abuse and neglect. Do you know what they mean? They include acts of commission and omission and are preventable. Child abuse and neglect include acts of commission and omission. What are acts of commission? Acts of commission are deliberate and intentional. However, harm to a child might not be the intended consequence. Some examples include physical abuse, sexual abuse, psychological abuse. What are acts of omission? Acts of omission are the failure to provide for a child's basic physical, emotional, or educational needs, or to protect a child from harm or potential harm. Some examples include physical neglect, emotional neglect, medical and dental neglect, educational neglect, inadequate supervision, exposure to violent environments. About 1 in 7 children experience some form of child abuse or neglect in the last year. But we know the problem is underreported. That's why a consistent definition is so important. The good news is, we can stop child abuse and neglect before it starts. What can we do? We can work together to promote safe, stable, and nurturing relationships and environments so all children reach their full potential. Some strategies to consider include strengthen economic supports to families, change social norms to support parents and positive parenting, provide quality care and education early in life, enhance parenting skills to promote healthy child development, intervene to lessen harms and prevent future risk. These strategies help create families, neighborhoods, and communities where every child thrives.